Hello, everyone. Thank you so much for joining us tonight. My name is Justin Gillespie. I am better known as ADHD Therapist Jay, and I appreciate you joining us for our Superior Center's training on evaluating and diagnosing ADHD for social workers, counselors, and other psychotherapists. I am going to shut this door real quick because I just realized my dog is out here eating, and you might hear them clank in. My other dog's getting in from doggy daycare. My wife's bringing them home, so let me just shut this real quick. I should have did that before we hit record. I just realized as he was eating, I was like, oh Lord, that sound's going to distract me a little bit. So thank you so much for coming here. I appreciate it. This is our beta training before we turn this into a CEU course. So any sort of feedback you have whatsoever from just things you want added, just things you notice in the presentation, please feel free to contact me or email me about those. We will also in the next day or two send out a survey once we send out the recording to everybody. So that way everybody has a chance to review it. I'm already seeing a small typo up there for psychotherapist. That's okay though. But like I said, my name is Justin Gillespie. I'm a licensed clinical social worker, therapist for ADHD. I'm a speaker, educator, owner of Superior Center and Thriving Enhanced Services here in Michigan, and we are getting ready to expand our ADHD services outside of Michigan as well too. And more recently, I am a published author. So big long bio, but I did all the work, so you guys are going to hear about it. All right, perfect. So let's go ahead and get into this. First and foremost, if you want to stay in contact with me or you have any direct questions about today's presentation and today's class, you can either follow me on TikTok or Instagram, or you just get in contact with me through my website. There is all of my codes right there. I'm going to leave them up for just a couple seconds just so you all can see them. We will probably, for the purposes of this class, for the purposes of time and just getting a good amount going with time, we will probably just kind of scroll through tonight, and we will either not do questions directly or we will do them maybe toward the end just because I want to make sure we get a ton of material into this. I will try to be as clear as I can. If there are immediate questions you have, please drop them in the chat. I will try to answer them as we go through tonight. But for the purposes of this class and time consumption, I just don't want to do back and forth with stuff just because you guys are very busy, I'm busy, and we have a lot of information to get through tonight. All right. Is it working? There we go. Okay. Canva is just acting really weird with Zoom tonight. Man. Is it just a white screen for you all? You can go ahead and put that one in the chat. I am just trying to figure out why it's doing that because it's supposed to go to the next slide. I wonder if it's just like the internet connection, maybe. You can see them from down below. Okay. I'm going to try something a little different then because I wonder if the way I have it shared is like slowing down the screen. So give me 1 second. I feel like my professors in college when they needed to do tech support, but that's okay. This is why we have this going on right now, right? And this is the beta training. So we'll go ahead and do that. You make fun of them, and then all of a sudden all the stuff happens to you later in life. It's weird. Okay. I'm just trying to figure out how I can do full screen and present full screen. But now where did the Zoom go? Okay, whatever. We're just gonna do it like this. We're gonna go ahead and share the screen first. So that way you guys are there. We're just gonna share the whole screen. And I don't know why it's being extra today, but that's okay. It wouldn't be an ADHD training without a little bump, I suppose. So hey. All right, perfect. Did it. Great. Okay. Does this look better now? Is this not a white screen anymore? Okay, perfect. You probably see all the chats coming up too, but that's how I did this maybe. I'm not sure, but that's okay. All right. I will send my professors an apology later when I was 20 and made fun of them for not knowing how to, convert a PDF because here I am on the struggle bus right now teaching. Okay, so tonight, let me go back just a little bit. So the objectives of tonight are going to be, first of all, we're going to review the DSM-5 criteria for ADHD. I want to make sure you guys have a clear understanding of it tonight. I will give you a spoiler alert. That is going to be the part of this training that's going to be especially dry, just so you know. Whenever we're doing DSM material, it's not going to be fun. It's just going to be straight to the point. I'm going to make it as painless as we can, okay? We're going to explore some screening tools and the evaluation process. We're going to clarify the difference between an assessment, evaluations, and testing tonight because I think these terms are often used interchangeably and they, especially with testing versus evaluations, they should not be, right? I often hear doctors saying they need a psychological test when they need a psych eval, right? Two totally different things. We're going to determine a diagnosis of ADHD and ruling out other diagnoses or factors, and we're understanding what to do after the evaluation process has been completed. Okay, so we're going to talk about our follow-up process after you've done the evaluation, after you've maybe written your report or your letters or whatever, however we do it, right? And then we're going to talk about what you do afterward. And so by the end of this training, you will have a better understanding of how to diagnose ADHD and will feel significantly more comfortable if you had to diagnose somebody right after. At least with my beta class, this is what you're going to be rating. So if I did not do that, let me know so I can make some tweaks before we turn this into a CEU. Hopefully you all walk out of here today just feeling great. Okay, so I want to have us watch just a few videos real quick. They're decently quick, but this will be about 10 minutes or so for both videos combined. But I just want to give you guys a good overview of what exactly is ADHD. If you cannot hear the sound, please let me know. I have hooked this up and I should have synced well to where when I'm sharing on the screen, you should be able to hear it. So let me just start that video and just drop in the chat. And just drop in the chat if you don't hear the sound.
Definitions and Answers series, where I explain common terms related to ADHD. Since this is the first video in the series, let's start with the basics. What is ADHD? Attention Deficit Hyperactivity Disorder, or ADHD, is a neurodevelopmental disorder as defined by the American Psychiatric Association in the Diagnostic and Statistical Manual, or DSM. ADHD is currently diagnosed in both children and adults based on the symptoms of inattention and hyperactivity or impulsivity. Two of several signs of inattention include making careless mistakes or having difficulty focusing. A few of the many signs of hyperactivity and impulsivity include fidgeting or recklessness, trouble sitting still, or interrupting and blurting out answers. While everyone does these things sometimes, not everyone has ADHD. An ADHD diagnosis requires at least 6 symptoms that are beyond what is age appropriate, that significantly impair multiple aspects of one's life, such as home, school, and work, that have persisted for at least 6 months, been present since before the age of 12, and can't be better explained by a different condition. Not everyone with ADHD has the same symptoms. In fact, ADHD diagnoses are separated into 3 presentations: primarily inattentive, primarily hyperactive or impulsive, and combined type. There are different levels of severity, and people with ADHD often have coexisting conditions, such as learning disabilities, anxiety, or depression. They can also be gifted. The term for this is twice exceptional. While there is no cure for ADHD, it is highly treatable. There's no single treatment that works for everyone with ADHD. The recommendation based on a ton of research is multimodal treatment, medication to manage symptoms, and behavioral therapy to develop the skills and strategies necessary to minimize impairment. Those with ADHD often struggle with everyday tasks and are at a higher risk for negative life outcomes, such as divorce, job loss, accidents, and addiction. At the same time, many people with ADHD credit their success to the unique ways in which their brain works. ADHD symptoms such as impulsivity and distractibility can translate into creativity, curiosity, a willingness to take risks, and an ability to think outside the box. Fun fact, the name ADHD has only been around since 1987, but the condition itself has been described by physicians at least as early as 1798. So it's nothing new, and our understanding of ADHD is constantly evolving. What it is, what causes it, how it affects us, and how to address it. For example, you might hear many experts refer to it as an executive function disorder. And while this isn't listed in the current DSM, emotional dysregulation is also a well-researched aspect of ADHD. As we learn more and more about ADHD, the definition will definitely be updated in both the DSM and the ICD, which is the other major reference for medical definitions. Whatever we call it, and however we define it, those with ADHD experience its impact on many aspects of their lives. If you'd like to learn more about ADHD, check out my ADHD Essentials playlist here. And if you'd like to support this work, consider donating to How to ADHD on Patreon. The brain advocates shown here and all.
All right, we're gonna move to the next one now.
Hello, brains, and probably people sent here by brains. I get it. It can be hard to understand ADHD and even harder to explain it to others. Most ADHD behaviors are things everyone struggles with once in a while. Losing your keys, spacing out during a conversation, forgetting to turn in an assignment. Sound familiar? Yeah, and when someone with ADHD does these things a lot, it's easy to assume that it means the same thing as if someone without ADHD does them. Once in a while is understandable, but if it happens a lot, they must not care, or not be trying hard enough, or not be very good at stuff. But before we judge their behavior or write them off as a bad whatever, it's important to remember behavior is affected by the brain, and ADHD brains develop and function much differently from average or neurotypical brains. Those differences can be valuable, which is why, as someone with ADHD, I wouldn't trade my brain for the world. But without the right support, they can also be incredibly impairing. The struggle is real. It's also invisible, which can make it very hard to see. So to help you understand what it's like inside the brain of your ADHD person, we reached out to our community of ADHD brains, as well as the community at understood.org, to ask how they explain it. For example, fun fact, despite the name, we don't actually have a deficit of attention. When we forget to change the laundry or have trouble focusing in class, it's because our brains have trouble regulating or effectively shifting our attention. So sometimes our brains jump from one thing to the next, and other times our brains actually zero in or hyper-focus on one thing, and it can be hard for us to pull ourselves away. As Eric Peterson puts it, neurotypical brains have a 1 through 10 dial they use to regulate their attention. With ADHD brains, our dials have 2 options, random and 15. And this applies to all aspects of our lives. The ability to regulate attention is part of something called the executive function system. It's kind of like our brain's self-management system, what allows us to plan, prioritize, and sustain effort toward a goal, say, making dinner, without getting sidetracked. It's what allows us to inhibit or not act on our impulses and ignore distractions so we can stay on task and switch when it's time to switch. In the ADHD brain, executive functions develop much more slowly than in neurotypical brains. And we have a deficit in the brain chemicals that help them function. So we usually know what to do and have the best intentions, but our executive function system isn't always developed or functioning well enough to effectively help us do it. And it's just as frustrating for us as it is for anyone else. Haley Melville explains it like this. Your brain is like a secretary, and you're the CEO in a meeting, doing a task. In a neurotypical brain, their secretary greets guests, potential distractions, lets them know that the CEO is in a meeting, and either encourages them to make an appointment or shows them the door. My secretary either lets everyone into the meeting, nor lets no one in, even if it's something important. Another executive function is working memory. That's our ability to temporarily hold information in our head so we can work with it. Like look at a recipe and then remember the steps while we cook. It's our brain's version of RAM. Everyone has a limited capacity of working memory, but it's often more limited in those with ADHD, which is one reason we might blurt out an answer before we forget it, or ask you to repeat what you just said. Timothy Warnke says, it's like my brain is a whiteboard and I have to write down everything that's happening right away. But I write kind of big, so pretty soon I have to erase a bunch of stuff to make more room. By the way, that's also why we tend to have trouble following multi-step directions. It's also why Post-it notes are helpful. Another fun fact about ADHD, not everyone with ADHD is hyperactive, at least not on the outside. ADHD has 3 different presentations and they can change over time. So even if someone doesn't look like they have ADHD, they still might. Even if they're not bouncing around the room, their brain might be. It's often referred to as internal restlessness, and it's exhausting. Diana DeVader Murray explains her mind like being on a hamster wheel you can't ever get off of. Deborah Credible says it's like a pinball machine with the ball constantly hitting and bouncing between all the bumpers. All this energy can be great when we can direct it well. It often shows up as creativity, generosity, curiosity. We tend to think outside the box, and we're 3 times more likely to start our own business. But for us to take advantage of our brain's strengths, it's important that we learn to manage our ADHD, which often means using a combination of medication and other strategies. ADHD expert Dr. Ned Hallowell explains it like this. Having ADHD is like having a race car engine for a brain. It's very powerful and it can propel you to win races. There's just one problem. You have bicycle brakes. But with the help of a brake specialist, you learn to strengthen your brakes and control that powerful engine. Then your race car stops running out on time and starts winning races. Because we do tend to crash a lot while we're building up those brakes, those of us with ADHD tend to get corrected or teased more often than our peers. And unfortunately, another aspect of ADHD can make that extra painful for us. Our brains don't just have trouble regulating our attention, they have trouble regulating our emotions too. Jennifer Peterson explains, when it comes to emotional dysregulation, it's like I have a really bad sunburn. Even a playful slap on the back hurts so bad. If you didn't know some of these things about ADHD, don't worry, I didn't either until a couple of years ago, and I actually have it. I thought I was just too sensitive, or a space cadet, or weird, because that's what I was always told. And I'm not alone. That's why ADHD Brains made this video and why we hope you'll share it. When our ADHD symptoms are seen as personality defects, it can be hurtful. And worse, we believe it. It takes a huge toll on our self-esteem and can lead to other conditions like anxiety and depression. And honestly, it's really confusing. As Comiendo Biscocho puts it, it's like being the smartest, stupidest, most motivated, and laziest person in the room, all at the same time. But if we and others understand what our challenges are, we can accept them, find strategies to help us work through them, and more importantly, stop beating ourselves up about them so we can focus on more important things, like what we're good at. And we can stop writing off ourselves or others for being different and start appreciating what that difference can bring to the world. Thanks for watching. There's a lot more to learn if you're
Okay, so that is the How to ADHD YouTube channel. Her name is Jessica McCabe. I highly recommend watching her TED Talk on ADHD. I watch it at least once or twice a year, and every single time I watch it, it makes me cry because it's just so relatable as somebody with ADHD myself. And she describes what it's like living with ADHD from childhood to adulthood in a very honest way. That's very touching too. So I would recommend watching that TED Talk and checking out more of her channel because you will learn a lot about ADHD just from that channel. I always say from the time I spend on her videos, I should probably get CEU credits because she's just that good. All right, so let's go on and get on into it. So your first lesson for tonight, as far as evaluating and diagnosing ADHD, is a sign is not a symptom, and a symptom is not a sign, okay? So what do I mean by this exactly? So a sign is an observable indication of a disorder, whereas a symptom is a self-reported psychological or physical effect of a disorder that is also listed in the DSM, right? That's what we need to use in order to actually determine do they have a symptom of it. So an example of a sign would be kind of like being on edge and not able to relax, right? That could be a sign of anxiety. That could be a sign of ADHD. That could also be a sign of PTSD. That could be a sign of actually quite a few things, right? So depending on how it's manifesting, right, you have to really go in to determine what is the sign a symptom of. So a sign is where it starts off as like, okay, I see this happening. Is this really ADHD or something happening, right? So if somebody is moving around, let's say in a chair, they can't sit still, right? It's your job to determine, okay, why can this person sit still? What is going on right now, right? Is it a new environment? Does this environment remind them of a past trauma that they've had, right? Because that could be a sign of PTSD or a symptom of PTSD, I guess I should say. But it could just be like this is how they are everywhere. They're here, they're kind of like this at home, at school, at work, at their mom's house, at their dad's house, at grandpa's house, wherever they're at, they're kind of like this for the most part, right? So that's how you can determine if it's a symptom of ADHD when it comes to sitting still or being fidgety versus anxiety versus trauma, or even substance use, right? So if you get into it, there are certain substances that make you move around a lot more compared to others, right? So maybe they did a substance recently. So if you work in a rehab, that's going to be very important for you to distinguish. A big thing that we also talk about that we're going to get into probably later tonight, but I'm just going to say it for the record, is that you have to determine are the symptoms medically induced or substance induced before you can diagnose ADHD. So if you have somebody coming into a rehab, technically speaking, you shouldn't really be diagnosing them with ADHD and present day symptoms until you have a confirmed period of sobriety. All right, so let's get into the what is the difference between an evaluation, testing, screenings, assessments, all that fun stuff, okay? So when we say assessment, we're more so talking about an umbrella term for the purposes of this training, right? It should be for the purposes of our life and our work, but these are often used interchangeably, and it's just going to take too long to educate everybody in the world on how they should actually be referring to these, right? So for the purposes of this training, an assessment is an umbrella term. It can refer to testing or evaluation. I sometimes catch myself using these interchangeably, even though I'm doing this training today. So as I say them, I am going to try to correct myself because I'm sure I'll slip up at least once or twice during this. Um, but for the purposes of this, they are totally different meanings, and assessment is the umbrella term for everything. Okay. So when you go into testing, we're going to start there. This is going to be more in depth and it includes a clinical interview along with testing tools standardized for psychological assessments or psychological instruments, I should say, right? So this is going to include what we have in an evaluation, which you'll see below, the clinical interview, the biopsychosocial screener tools, all that. But it's going to be measuring for something. It's going to be measuring, how many times are you doing something? How many times are you hitting the space bar when it tells you to do this on this computer exercise? How many times are you fidgeting? How many times are you moving, right? It's really gathering a lot of data and comparing it to other data on different types of tests, right? So for tonight, we're not going over testing, right? This is for psychologists. The evaluation, social workers, therapists, psychologists, anybody can do this one, right? Which is why we are training on this one. I also always say too that testing, it is super expensive and there isn't a whole lot of accuracy that's a lot more compared to evaluations, which we're going to get into later into this training. They are necessary sometimes just because a second opinion is warranted, different methods are warranted. Sometimes people have complex mental health issues to where that is going to be needed. Also, for an autism diagnosis, you are going to have to go through testing too for psychological testing. But an evaluation we can all do. So when we get out of school, depending on what your state you're in, because some states also do have certain laws and regulations. I believe I've looked it up though recently to where all 50 states in America can now diagnose ADHD at a social work level. Before there were some states that wouldn't allow you to do that. Some left it as you could do it only at the clinical level. For the purposes of this training, I always say if you're at a limited license or lower license level when it comes to social work counselors, anything like that, if you need a supervision signature on your note, you're going to need a supervision signature and review on your evaluations, just for a general rule of thumb. But the evaluations, that's a clinical interview, your biopsychosocial screening tools. Anybody can do this right now as long as you have that degree and that license. And then a screening, so a screening is like the GAD-7, the PHQ-9, the PCL-5, the ASRS, if you're familiar with any of those, right? These are screeners. These are just little questionnaires that we have, and they're very brief and they're very narrow in scope. Do not diagnose somebody with something just because they have a screener that comes out a certain way, right? Because I get a lot of people who I work with who get diagnosed with bipolar disorder, with borderline personality disorder, so many different disorders before they'll get diagnosed with ADHD because somebody did not take the time to actually ask clinical questions, to ask follow-up questions, to ask for context. All of that's for the purposes of the clinical interview and the biopsychosocial, right? So that is why we do that because we want to get the background info. To be honest with you, you technically don't even need to do screening tools in order to diagnose somebody if you do a really good, thorough clinical interview and biopsychosocial, right? Screening tools are meant to help you. They're not meant to be the end all. So on the flip side, if somebody comes out to do an ADHD assessment and they come out negative, that doesn't necessarily mean that they're negative for ADHD. This is just more of a guide. It's just supposed to give you a clue and be somewhat helpful towards you. One of the reasons behind this, and we get into this in a little bit here, but one of the reasons behind that is because screener tools are subjective. It's how they look at their life and how they interpret the question. So it's your job in the clinical interview to really determine, like, okay, why did you answer the questions in this particular way, and really get to know the person a little bit more. Does that make sense to everyone? If that doesn't make sense to everybody, go ahead and drop it in the chat for me. But that's essentially the difference between a psychological test and an evaluation. The evaluation is just going to be the clinical interview and a biopsychosocial, and we might do some screeners too. All right, I'm not seeing any confusion on that. So to give you a good reference point here too, screenings take like a few minutes, whether the client is doing them themselves or you are administering it through verbally reading to them and then giving them context for the answers, right? But again, that makes it super subjective too. So keep that in mind. So just because something comes up positive, it doesn't mean they have that diagnosis. If you have somebody with coming up positive for anxiety on the GAD-7, it doesn't necessarily mean they have anxiety. If they score a solid 0, that doesn't mean they're negative for anxiety too, because they could be interpreting questions a certain way. But screening takes a few minutes. Evaluations, you could see an evaluation be done in 30 minutes. I would usually stick to about an hour for mine at least, just so I get really good follow-up. But you could see anywhere between 30 minutes and about 2 hours or so, give or take, when it comes to evaluations. Sometimes for my evaluations, I also split them up. So sometimes they'll do 1 hour the first day. We come back a week later or a few days later. We'll do the second hour the next day. Sometimes that's easier for people. I do try to schedule them in just a 2 hour block just to get everything done, just because logistically it's easier. But, some people have lives and they have to break it apart, and that's totally fine. Testing is going to be the longest one. You could see psychological testing take anywhere between 2 to 8 hours in my research. I have seen some psychological tests take 2 days, and I've seen some clients do it over the course of like 6, 7 hours each day. So that could even be potentially a little bit longer. But just know testing is slow, evaluations are at a good speed, screenings are pretty swift and quick. So whenever we give a referral for psychological testing, what I would say to do in general is, first of all, when we're diagnosing or ruling out autism, you're definitely going to want to get that psychological test done. Now, there is a screening tool that we're going to go over later today that I do, depending for if you're a child or if you're an adult. We'll just kind of briefly touch on it. But there is the AQ for individuals that I like to do, the autism quotient for adults, and I believe it's called the CAS, the Childhood Autism Spectrum Test. Even though it's a screener, they call it a test. There we go, right? That one I like to use for children. It's just to see if there's any autistic traits there. It's not meant to diagnose autism, but it does give me a good indicator of if we should be referring for autism testing or not, right? So when we're looking to rule out or diagnose autism, we should be referring to a psychological test. When seeking a better understanding of an individual's overall intellectual functioning, as well as their specific learning style, as well as cognitive strengths or weaknesses, this is where we should be referring to psychological testing to get a very specific area of report, right? And then when evaluations do not provide us enough info for direction, we should probably be referring to psychological testing next then, because that's going to be the next step up. Now, some people would say, why wouldn't we just go straight to psychological testing then, right? Why would we even do an evaluation, right? First of all, psychological tests are expensive and a lot of times aren't covered by insurance, okay? So a lot of people with ADHD, when they have certain doctors, there are some doctors that are very adamant they want a psychological test. Um, some don't know what they're talking about and they do just want an evaluation once I get on the phone with them. Others, though, they do know what a psychological test is and they want their clients to get a psychological test. It's not always needed necessarily, right? For what they're looking to get it done with. So sometimes it requires us to do a little bit of education, but some doctors are stuck on it. If your client's doctor is stuck on it and before they'll write any sort of prescription, they want a psychological test, then you're going to refer to a place that does psychological testing. But I guarantee you it's going to be very expensive and the wait lists are going to be huge. I've seen some clinics around my area. I don't know what they're like around all of yours. Maybe you can drop them in the chat if you are familiar with this for people who've been referring out for psychological testing. Here in the Detroit area, it is anywhere sometimes between 6 months to a year in order to get psychological testing done. We found like one clinic that'll do it pretty reasonable within like a month or two, right? And sometimes that's even scarce for their clinic. But a lot of places they have a very large wait when it comes to this, and you need help today. And so at the end of the day, that's why I would say that we would do an evaluation first, because sometimes it's just not needed. Okay, someone dropped in the chat, same in Ohio, about 6 to 12 months. Okay. All right, so let's talk about limitations to evaluations and testing. So this is where we're going to kind of give you a little bit of disclaimer here because we need more work to be done when it comes for evaluations and testing, and I like to be very transparent about it, okay? So psychometric studies indicate that ADHD can be diagnosed reliably and validly, and there is ample research on the accuracy of behavioral rating scales and cognitive tests. So, with that being said, these are the things that we really want to consider for limitations. The first one's going to be our clinical interviews that we talked about for evaluations and testing. There is a lack of research on the accuracy of clinical interviews, which are primarily based on the quote gold standard diagnosis of ADHD in most research. The reason this is because, again, clinical interviews are being administered by humans. We read questions, and we all, including therapists, interpret questions differently, right? So, not every single clinical interview is going to be exactly done the same because you may read a question, like I'm trying to think of one from a screener that I have to read often, right? Um, have you, like, let's just say you have a question like, have you ever stayed up all night and can't seem to get to sleep? Sometimes that might be on it. Sometimes the different clinical interview forms will be more formal. Some will be kind of casual like that, right? So for some people, when they're asking that question, the therapist may think, well, that kind of refers to mania, right? If they need to explain it further, right? Others will say, oh, well, that just is like referring to insomnia or whatever, right? So even when you ask these questions, the way you're asking them and the way you're clarifying and explaining them, they're going to be affected, which is why clinical interviews do have a lack of research when it comes to the accuracy. Because again, we're asking questions in different ways and not in an objective way, because that's just how language works at the end of the day. For neuropsychological tests are not as sensitive for diagnosing ADHD, and the disorder should be diagnosed based on the patient's history. So a lot of people, what I know is they'll disregard the actual history that that client has, and they only go off of the psychological testing that's done, the psychological testing exercises that are done. And some people, they perform better when they know they're under pressure, right? So you may be going to a psychological test and you think, oh my God, I have to perform right, especially children, right? So they very well may put in a little extra effort and then they just dismiss it and say, well, they don't have this, right? That's totally inaccurate. Effort and cooperation. So there is no single test to determine how much effort or motivation a student or a client is putting forth during an evaluation. And research suggests that effort and cooperation can explain up to 50% of the variance in scores on a neuropsychological test battery, right? So sometimes, especially kids, but adults too, they just don't want to put in the effort. They don't want to do this. It's boring, it's long. Who wants to do this? So sometimes you're going to get inaccurate ADHD diagnoses from a psychological test just because they're going off of the test and they're not going off of the history of the child, right? And then vice versa. Some of them, what is happening is they perform way better and then they're not getting a diagnosis because they put in the effort to do it that day. Computerized tests of attention and vigilance. These are not generally useful for diagnosis because they have a low dyslexia, specificity. I cannot say words. A little bit of dyslexia coming out, and sensitivity, specificity. Somebody drop it in the chat because I cannot read it today, but you know what I'm trying to say. All right, they are useful as they can be useful as research tools, but the results may be applicable to a patient's natural environment, right? So again, this kind of just goes along with the testing tools that we talked about. Some people they're going to put in more effort on something that's more computerized. I do know that there is a test that a clinic around here uses called the QB test. I have sometimes referred people out to that just because it's a second opinion. But again, I've had people who go in with full histories of ADHD symptoms, and in the report, they'll acknowledge it. They're very thorough with it too. So they acknowledge like the history adds up to be ADHD, but in the office visit, the computerized test showed they did not have ADHD. So it's just another piece of data that will either support you or can just throw things off a little bit. Okay, someone said in here, same in Phoenix, really long waits and thousands of dollars. Exactly, right? So if we don't have to refer that to anybody or make somebody go to get that, if we don't have to, why are we making people spend thousands of dollars for something they don't necessarily need? Now, some people need it. Absolutely, they'll need it, right? There are some people who will, and we just got to put up with that and figure out how we can get those barriers across, whether it's time or budgeting or getting funding or whatever the case may be with our clients, right? But a lot of people don't need to go get a full psychological test, especially with how the accuracy rates compared to clinical interviews. And as you can see, there are limitations to both anyway. So if we're going to make somebody get one or the other to get an ADHD diagnosis, why would we make them take the longer wait that's more expensive if we don't have to? Significantly more expensive. All right, let's get into the DSM-5 material. This is where it's going to get really dry and really slow, and I'm sorry. I'm glad that we went over some of the criteria as well as just what actually was ADHD with the videos previously from Jessica, but this is where it gets a little bit boring. Okay, so as you heard her say earlier, there's three different types of ADHD. There's the inattentive type, which we used to call ADD. Now that's under the ADHD spectrum. We have hyperactive type ADHD and then combined or hybrid type ADHD. Most people you're going to see are going to fall under the category of combined or hybrid type. So if you think combined type means, oh my God, they have two ADHDs, are we sure of putting it? This is usually how this comes out. Most people aren't going to fall under inattentive type or hyperactivity type. They're going to fall under the combined presentation type. You're going to hear people talk about they are hyperactive or they are inattentive type. There are some people who do, but most of the time that's because we have a lack of history and then diagnoses just don't get changed. We know how that goes. We get into clinical work with people. We never change a diagnosis. We don't update it because sometimes it doesn't matter. Just being on the real, right? So go ahead and drop that in the chat if you have an amen for that one. Because sometimes the diagnosis doesn't matter from the therapy perspective, anyway, right? But with inattentive type ADHD versus hyperactivity type versus combined presentation, it's all treated the same with behavioral therapy and medication. So for our purposes, it doesn't matter nearly as much. You will have people who say, they're inattentive or hyperactive. Sometimes they don't even know if they are. They just know they present a certain way, or people say they present a certain way, and they'll just say, I present that way. Either way, it doesn't really matter from the clinical interview perspective. You want to just decipher from the symptoms they have anyway. So those are the three, though, that you will be going off of. There's two others we will go over toward the end of the DSM portion, but for the purposes of this, there's three types right now. All right, so ADHD is characterized by a persistent pattern of inattention and or hyperactivity and impulsivity that interferes with functioning or development. The DSM-5 criteria for ADHD are as follows, and the DSM-5 TR now. I don't think there was any, it doesn't seem like when we looked, there was any updates to this diagnosis, just so everyone knows. All right, so first and foremost, so what we're looking at right now is we are looking at the inattentive type ADHD symptom criteria. So what you need to know for this is that you have to have symptoms for at least a 6-month period. That is inconsistent with their developmental level, and that negatively impacts directly on social and academic or occupational activities. Okay, so if they are not causing negative impacts on social, academic, or occupational activities, and by the way, when you do children, they have a life out of home and school, right? They have friends, they have acquaintances, they have clubs, they have all sorts of things they do, right? So do not just judge somebody's progress just based on home and just based on how are their grades, okay? But you're going to have these for 6 months, inconsistent with their development levels. And if they're a child, you have to have 6 of the following symptoms. When they're an adult, or as we measure it for ADHD, 17 years old or older, 5 symptoms are required, okay? So the first one we're going to go over is often fails to give close attention to details or make careless mistakes in schoolwork, at home, or other activities. This is like the person who's constantly forgetting to carry a 1 over in algebra. This is the person who is, just missing questions on their homework or their schoolwork or what have you, right? This is the person who forgets to bring, things to class. Some of these symptoms overlap with one another with examples, just so we're clear. But this is someone who forgets to bring like a simple tool that they constantly need. They're constantly kind of overlooking things. Often has difficulty sustaining attention in tasks or play activities. This is the person who's a little bit spacey or a little bit daydreamy. Often does not seem to listen when spoken to directly. This is going to be the person who says what a lot. Hey, can you do that? What can you do? Okay, yeah, I got it. So sometimes it takes them a second to kind of like get it together. Sometimes they don't get it together at all. Sometimes they're just like out here, like they're looking directly at you, but it just seems like they're not listening, right? That has to do a lot of the time with verbal processing of language. And sometimes their brain hasn't caught up to it yet, or they're only hearing half of the sentence, even though they can physically hear all of it. So they're not comprehending everything. They're doing that too, by the way, for the purposes of the DSM criteria for getting rid of medical. You want to make sure that they probably don't have like any hearing loss or assessed for that too, just so we're clear. Often does not follow through on instructions and fails to finish schoolwork, chores, or duties in the workplace. So a lot of unfinished things. A lot of things started, not a lot of things finished, or sometimes not a lot of things started. Often has difficulty organizing tasks and activities. So getting your tools together, getting your steps in order, gathering your thoughts. Notice how the word often comes up too, by the way, and there's going to be screeners that we're going to go over today that say like a little, very often, often, right? I want you to pay attention to those too, because there's a reason we have the word often in here. It's not just some of the time. Oh, there is one question on when we're going to go over that marks you positive for sometimes. I believe it's appointments, if I remember correctly. But just know often comes in here a lot and it comes in for a reason. Often loses things necessary for tasks and activities. Are they constantly losing something? Are they always looking for something? Is often easily distracted by external, I call it external because I can never say this word either, external stimuli. So okay, so this just happened to me just now, actually. Perfect timing. Thanks, wife. So my wife is in the bathroom right now, and I heard the toilet slam, and that's supposed to be background noise. A lot of us with ADHD, we don't have that background noise filter to where we don't hear it, or we may, with neurotypicals, you might hear it a little bit, but it doesn't phase you. For us, as soon as I heard it, I was like, oh, there's a pause. Looked up, there's a pause, right? And this happens often, right? Not just a little, not just some of the time is often forgetful in daily activities. So again, this goes back into your spaciness, but it also maybe you forget what you're doing. I call this the sim action where okay, so drop in the chat real quick. Who are my Sims people? Who plays the Sims? And knows what I'm talking about, where you go and you make your sim go do something and then you just cancel an action on the sims. Maybe you were going to make your little sim character go make itself some lunch at the kitchen. And then you said, nope, we're not doing that. And you just leave them stand there for like 2 minutes, right? This is what I call the sim action because you just cancel the action and your sim's just sitting there like, I don't even know what I'm doing. So that could be also forgetful in daily activities. All right, so for hyperactivity and impulsivity, same criteria we talked about earlier. 6 or more for children, 6 months needed, 5 or more needed for 17 and up, okay? And it has to be at the developmental level. And note, the symptoms are not solely a manifestation of oppositional behavior, defiance, hostility, or a failure to understand tasks or instructions. I did not say that one previously, so I do want to note that real quick for you. All right. Often fidgets or taps with their hands or feet or squirms in their seat. Okay, so this is me. This is where I come out. I have combined presentation, but this is where my primary presentation comes out a little bit. I am constantly moving. I am constantly moving my hands. I'm constantly sipping on something. Believe it or not, that is a fidget too. That's why I have this cup in addition to my throat. Just helps a lot. But I need to be doing something with my hands. I need to be doing something. My keys become fidgets. This is really noisy. Probably getting on your nerves right now, so we'll shut that up. Where's like something I used tonight other than my hands? I think I forgot something. I have these 10 business cards that have been sitting on my desk for weeks, and literally I just put them right next to each other. And then like so I fidget with it. Now this could also, by the way, be an autistic thing because I am autistic as well too. So little fun fact there. But I like to put things next to each other, put them in an order, which is weird for ADHD and autism. That's a whole separate training. But one of the things I'm doing is I'm putting them in a pile and then I'm destroying the pile and putting them back in a different way, and then make shapes with these business cards. Anyway, that's kind of what we look at in a few different examples for often fidgets or taps with our hands or feet or squirms in our seat. Constant moving. Often leaves our seat in situations where remaining seat is expected. Now, for children, this is a lot easier to look at because what are children doing? They're going to their friend, they're seeing their people, they're like bouncing off the walls a little bit. And the kids with ADHD, they're doing a lot more. For the adults, this is like if you have an office job, you're constantly going to the water cooler. You're constantly going to the bathroom. Maybe you're not even going to the bathroom to use the bathroom, but you need to go to a new environment. You need to be out of your seat. This goes along with fidgeting in our or squirming in our seat, but also changing positions in our seats too. This could kind of do that too. So maybe we need to stand up real quick, or maybe we just need to really change positions in our seat. You'll see these two symptoms often together. It's very rare where you'll have somebody who fidgets with their hands or feet and then often leaves their seat. It's very rare you'll see someone with ADHD that has one or the other, I notice. Not necessarily um not necessarily a diagnostic criteria to have both, but that's just my observations. Most of the time these two are going to be together. Often runs about or climbs in situations where it's inappropriate. In adolescents or adults, this may be limited to feeling restless. Okay, so again, you can go back up to that fidgeting a little bit. We can't sit still, we can't rest, we can't relax. Often unable to play or engage in leisure activities quietly. So these are the people who can't do homework quietly, they can't do schoolwork quietly, they can't play quietly, they can't just play a video game and be quiet. They're often making some sort of noise a lot of the time, typically verbally. Sometimes they're just banging a bunch of stuff too. They're kind of like the bull and I think what was the phrase, bull in a china shop or something like that? I can't remember. But anyway, they're often like kind of bouncy, maybe a little clumsy too. I don't know why like they don't have like a version of like clinically clumsy on here, by the way, because that's very common with ADHD as well. But I digress. Maybe it comes along with just fidgeting and squirming. I don't know. And not being able to sit still. Okay. Is often on the go and acts as if they're driven by a motor. This is what I call the switch. When the switch is on, it's hard to turn off. So they're just going and going and going and going. This is also where we often see the hyperfocus happen. So if you've ever heard of the term hyperfocus, this is where we get locked in on one thing. So this training was a hyper focus of mine for a little bit one time. I built this training in about 4 or 5 hours, which is why we do beta trainings on these, by the way, with you all. So we appreciate you all being here because as I do these trainings, I have learned that I love to make the trainings, but I don't like to go over the details of the training. So sometimes I will find typos in my trainings. I will find just random things in them that I didn't take out. But this was a hyper focus. I built this training in about 4 or 5 hours. Often talks excessively. This could also be oversharing. Often blurts out answers before questions have been completed. So this is the kid that can also be, or the adult even, that can be very predictable of what people are going to say. So a lot of times we're right, by the way. We're right with what someone was going to say. But we still need to like let them finish their question because that's what, society expects you to have manners. And I agree with that. I also don't like being interrupted because let's say I get with another ADHDer that interrupts me, even though it's my toxic trait, a little hypocritical there. I get it. Because I have a little bit of problem interrupting people too. But when someone interrupts me, I forget what I was saying, right? And that's often what a lot of times with anybody happens, but especially with ADHD, you get another ADHDer, we forget what we were saying. Okay. Often has difficulty waiting his or her turn. In the adult world, so for kids, this is like waiting on game night, and waiting for their turn. This is getting antsy when they have to share and they're waiting on the toy, right? For adults, this is waiting at the grocery store, and after more than like 5 to 8 minutes go by, sometimes 2 minutes for some of us. Me, thank God for Instacart, thank God for DoorDash, right? Am I right? Although theoretically that's longer too. We'll get into that one another night. But anyway, I digress. Um, yeah, this is going to be the us waiting for the copier at work, waiting in line at the store, and us externally going off or internally going off, right? So a lot of people think that just because I'm not going off, I'm like, why is this line not taking so long? Right? Just because we keep it all in our head, it doesn't mean we're not bothered by it and we have difficulty waiting our turn. Because most people, what they do is they wait patiently. So that person who's raging, they might be a jackass. You came to the late show, so we're just going to say it, right? They might be a jackass, but they also might have ADHD or both because we can be jackasses. I have been in the past myself. So all I'm saying is this, like when you see that person going off, just think, they have a hard time waiting in line. Maybe they have ADHD. We don't diagnose our strangers, but we can speculate. All right. Often interrupts or intrudes on others or butts into others' conversations. Or for children, this is often butting into their game. So if they're playing games, they're playing with a group of the kids, and they just like come right in, right? No, no waiting, no whatever, right? And they're often just jumping right in, or they're interrupting a whole game that's going on. You'll see that with kids a lot too. Target pickup orders for life, someone said. I love it. All right, so that is the criteria for the inattentive symptoms and the hyperactive or impulsive symptoms. Now, several symptoms are present in two or more settings. We talked about that earlier. Remember, there's more to life than home and school or home and work, right? So you also want to look at friends or relatives or in other activities, right? Somebody might excel at school and still have ADHD. Now, there's a whole other thing that we can get into about that. We probably will tonight because some people, have accommodations in school without having formal accommodations in place, if you get what I mean. The teacher might just like them because they're nice and pleasant, so they get to turn in work late. So if you ask the teacher, oh, there's not a problem here, too, right? So this is where assessing for ADHD gets really subjective, and we have to figure out how to pull out objective information, right? If the teacher says the assignment is due Tuesday and they can't get it until Thursday or Friday half the time, even if the teacher doesn't mind it and they're flexible, that's still a symptom of ADHD, even if the teacher themselves is not calling it that. A lot of doctors will get the Vanderbilt assessment, which we will also go over tonight, and they will see a very kind, accommodating teacher not ever label any of their symptoms correctly. And they will just go off of that and say this child doesn't have ADHD, even though they're constantly turning in late, even though they're kind of bouncing off the walls, even though they can't sit still. But because the teacher doesn't find it a problem, they rated them all, no, not at all for all of these things, right? So it's our job as evaluators to really determine and decipher the information. There is clear evidence that the symptoms interfere with or reduce the quality of social, academic, or occupational functioning. The symptoms do not occur exclusively during the course of schizophrenia or other psychotic disorder and are not better explained by another mental health disorder, such as a mood disorder, anxiety disorder, dissociative disorder, personality disorder, substance intoxication, or withdrawal. We talked about that in the beginning. So, my rehab workers, my drug and alcohol rehab workers, this is very important for you all to hear this one because you will be the ones who probably see this one most often, in addition to just working in an ER. All right, so here are the other two diagnoses I told you we're going to come later. So we have the inattention, or I'm sorry, the attention deficit hyperactivity disorder, other type, and the ADHD unspecified type. Okay, the difference between unspecified and other type is that an other specified diagnosis must be very close to meeting the criteria for a specific disorder. Maybe this means you meet all of the criteria except for two or more environments. So you give them an other diagnosis. And the clinician has to explain why it doesn't meet the criteria. Unspecified means the clinician is not sure which diagnosis best fits. So a lot of times you might see somebody come in to see you from a psych eval, and they can determine they have depression of some kind, maybe major depressive disorder, maybe they have persistent depressive disorder, but then they're also trying to decipher between anxiety and ADHD. So you might see someone with unspecified anxiety and unspecified ADHD. Other means it's very close. We're missing one or two things and we need more time. All right. So now we're going to go into screening tools in a moment. I don't see any questions or any clarities on that. I am trying my best to look at this, but I know for the purposes of this, I want to speed things up for everybody. I'm going to grab some water real quick. So if anybody wants to take a 1.5 minute break, go right ahead. Go ahead and stretch. I will be right back momentarily. All right, I'm back. I got my water. I've got my backup water here in my Stanley. So we should be okay for the night, I feel like. I'm just now healing up from RSV and I still have that dang cough. And I finally got it to where I'm not having attacks more than once a day with it. But the longer I'm talking, the longer I'm feeling in my throat. So hopefully we got enough water to keep doing this. All right, let's get started. So for screener tools with ADHD. So remember, these are our brief screeners that we use, and these are not the end all be all with anything. So I really want you to all to remember that. This is not the end all be all. Just because one of these comes out positive does not mean by default they have ADHD. Just because someone comes out negative does not mean by default they don't have ADHD. It all comes down to the clinical interview. This is just to help guide you and provide additional support or clarity. All right, so we're going to take a look at some of these tonight, and I'm actually going to email you out all of these screeners when I send the recording too. So these are all free on the internet. You can Google them, you can grab them, but excuse me, let me get some water. But for the purposes of just making your lives easier, this weekend when I send the recording out, you will have access to all of these in a link. So there you go. That way you don't have to go around and dig too much. All right, we're going to start out with the Vanderbilt assessment. Can everybody see this okay? Just because I'm switching screens. It said entire screen, so does everyone see this okay? Someone just drop it for me in the chat if they see this. Okay, perfect. Thank you. All right. Thank you, Julie. I appreciate it. We're going to have to go on a Target run one day. Okay, so here's what this looks like. It probably looks tiny for you, so I'm going to try to just blow it up a little bit. That's probably better. Okay. It's better for me too. Oh my God, actually. Okay, so on the Vanderbilt assessment, this is a parent informant one. Let me make sure they have the teacher one. Okay, and then they have a teacher one. Okay, so if it's possible to get one of these back from the teachers, get one of these back from the teachers because this is going to be more supplemental evidence that they are having issues in two or more environments. Again, you might have a teacher that's super overly accommodating, so they might mark never to a bunch of these behaviors, even if they are happening, because they don't see the child as a problem, which is a good thing. We don't want to see children as a problem, but we do want to be accurate with how we are describing their behaviors and symptoms and signs, right? So a lot of times these subjective assessments are kind of favoritismed a little bit. Sometimes teachers will mark very often for children who maybe have it often or occasionally, and they just don't particularly care for that kid. Sad to say. A lot of teachers are very helpful, though. A lot of them are very helpful toward us, right? Same with parents. Some are more helpful than others of giving us the information. Others are overly critical or overly passive. Okay, so the first things first is these are all going to be symptoms that they've had in the last 6 months. And the parent is going to mark if they were on medication or not. I'm not sure why someone would mark not sure, just so we know. Maybe we can have like a peer support version on this chat for a minute, and maybe someone can think of a reason for me. Because I have not figured out why a parent would not know if their kid is on medication or not. But we're just going to go with it. There's a not sure option, okay? This is important to know because you can show some evidence that a doctor needs to get them some medication if they were not medicated and having these symptoms. If they were on some sort of medication, whether that was for ADHD, anxiety, depression, or just physical health medications, right? That is good to note as well. And you should also be noting this in your clinical interviews anyway. So even if they leave this blank, this part shouldn't matter nearly as much, but it will give you some decent context as you go through the assessment. So as you'll see here, you have questions like does not pay attention to details or make careless mistakes with, for example, homework, has difficulty keeping attention to what needs to be done, does not seem to listen when spoken to directly. Do these sound familiar? These sound like the DSM, don't they? So this is based off of the DSM. I think it's almost correlated almost exactly with the DSM. So how you will score this is once they fill everything out, you're going to have a score sheet right here. Total number of questions scored, 2 or 3 in questions 1 through 9. Okay. So we're going to go back up for a second. We're going to do a lot of scrolling here. There's 1 through 9. Okay. You're going to just count how many of these questions were 2 through 3. Same thing through 10 through 18. So 1 through 9 is measuring the inattentive symptoms. And then this one is measuring the impulsivity symptoms. It also measures for other things too, because you get the total symptom score right here. You can also go for 2 or 3 and 19 through 26. Let's see what those ones are. So these could be more like oppositional ones. You also have some questions related to anxiety and depression here too. And then you also get to see their school performance, right? Same thing with the teachers. It's almost identical. It's a little bit shorter. I think that's like 43 questions for them. They used to use a different form. They didn't have this on there before, but you can also have your own mailing address put on there as well too, which is why this one's really cool. So when you're working with parents, essentially what you're going to want to do with this one is you're going to want to just give the PDF or email the PDF to the parent, and they can print it off, or they can just, if you have a physical copy, you give them a physical copy. And then they'll give it to the teacher essentially. And then either the teacher will mail it back or the parent will bring it in. And then there's a follow-up assessment too. So your initial ones are what you're going to mainly do for ADHD when it comes to like doing evaluations, just so you're clear. There's also, I found online, if you could dig deep enough, there's shorter versions of this too. Also, if you're in private practice, if you use therapy notes, the parent, what do they call it? The parent report, that's the initial report, and the follow-up report, that's built into therapy notes. So you can do it with them verbally, or you can just send it to them. I like that because, they just fill it out and then I just review it and it scores everything and it's really awesome. You'll have to do the scoring of the teachers, unless you have a teacher where you can set up your own account for that teacher specifically for a one-time use. I don't think most teachers appreciate that though. They just want to do the PDF and keep it going because, school is hard and they're busy and they're underpaid. So anyway, but this is how you're going to learn how to score these assessments, right? So for the predominantly, sound it out, Justin, inattentive subtype scores, you must have a score of 2 or 3 on 6 out of 9 questions for 1 through 9, and look at the score 4 or 5 on any performance-based questions 48 through 55. So that means you're having some sort of issue in school. So let's take a look at what those are then. Scrolling all the way back up. Yay. Oh, scrolled a little too far. Hold on. There we go. So you need a 4 or 5 for these ones, right? So overall school performance, reading, writing, math, relationship with their parents, relationship with their siblings, relationship with peers, or participation in organized activities. This key is going to be your best friend, especially if you're manually scoring, because I can't tell you the amount of times I forget which questions are what, where are we at, and I've done this a million times, right? So I'm often always looking at this. And they're just asking for one of them, right? So you just need a score of 4 or 5 or any of the performance ones. Same thing with the teacher side. 2 out of 3 for 6 out of the 9 items for 1 through 9. Score of 4 or 5 on any of the performance questions. Same thing with hyperactivity. Same thing with hyperactivity on both sides, okay? So you're just going to do exactly what this key tells you to do. And that's how you'll get the results as far as for a child goes. Now, again, your clinical interview should also support this too. So just make sure you're doing a thorough clinical interview. For combined presentation, you just meet the criteria for this one and this one at the same time. For oppositional defiant disorder screening, you must score 2 out of 3 on 4 out of the 8 behaviors on 19 through 26 and score a 4 out of 5 of any of the performance questions. And then as far as conduct disorder, it goes to the same thing too. Now, the teacher is not measuring for conduct disorder, just so you know. So you're not going to need to reference that one to have that because conduct disorder screening should be done just by the parents. And you see that here on the key as well. And then anxiety and depression score 2 out of 3 out of the 7 behaviors and score 4 out of 5. Now, sometimes this assessment is going to light up like a Christmas tree. And you're going to be positive for a lot of the things. Sometimes it's going to not light up at all, and you're going to be looking negative for a lot of the things, right? So, again, this is where a good clinical interview is going to come in place to ask follow up questions, to get context, and all that kind of stuff. All right, let's go ahead and get rid of that one. The next one is going to be the SNAP-4 and the Connors and parent teacher rating. So, as you can see with children, they're almost always going to have a teacher rating. The SNAP-4 also has a short version of it if you dig hard enough, just so you know. But it's very, this is going to be a similar-ish assessment, but it's going to be a little more to the point with scoring, I feel like, in my opinion, anyway. So often fails to give close attention to details or make careless mistakes in schoolwork or tasks. Often has difficulty sustaining information, or I'm sorry, sustaining attention in tasks or play activities. Often does not seem to listen when spoken to directly. Does this sound familiar? This is coming straight. This is coming straight from the DSM, just so you know. This is, I think, for the most part, these aren't even paraphrased. This is coming straight from the DSM. This is why I like the SNAP-4 a lot, especially because it's not as paraphrased either. But it's still a little subjective if you just give this to them to fill out. So you're going to look at not at all, just a little, quite a bit, or very much. Okay. Same thing that's going to go with your teacher, right? So for this one, you just give them this assessment and they fill it out. The parent fills it out. The teacher fills it out. And then you just kind of match it up to the DSM and however it's coming out. I'm just trying to see is there anything important on this one here too. So here's the scoring instructions. There we go. That's what I'm looking for. Okay. So check this out. So you're going to literally just list what the scores actually were. So a scoring template for the DSM, this is 4, but it's been carried over into the 5, just so we're all clear. So this one's technically with the language a little bit outdated, but goes off of the same exact thing too. For the dimensions of the clam and for the Connors index are presented below. So I didn't realize this one, but I think this one combines the Connors actually, because that's the next one we're going to go over. They look almost exactly the same though. But this is how you're going to kind of determine like what the scores are. Now, if you don't want to do all of this, because again, these are just like things that you're going to be doing to just add evidence to it, right? If you don't want to do all of this and do all the numbers and whatnot, right? Because the numbers aren't necessarily 100% necessary, because you're going to have to reference a DSM-5 anyway. You could just kind of see how many of them are quite a bit or very much, because that's going to be considered our often categories, right? Quite a bit or very much is going to be often. And you can also compare it to the DSM or the DSM symptoms for like, let's say ODD, anxiety, depression, and all that. But it'll give you very clear instructions on how to actually score these, how to do these, and how to interpret these. But again, this is going to be just something that you're doing to just add information to it. It's not necessarily going to be something that you're doing for the sole purposes of diagnosing, just based off of what this says. But it comes pretty close because it's written just like the DSM. This is going to be the Connors assessment. There's different versions of the Connors assessment too if you dig deep enough. This is just a teacher's one we're looking at right now. The day I did this, I could not find the parent one, unfortunately, but this is a teacher one. So this will be good just to look at what the teacher's looking for. I'm not a fan of the language though on here for some of them because the first one is defiant. Are you a defiant child? Like, okay. like whatever. But as you can see, this is not at all, just a little, pretty much, or very much. So this one does not have a score key. As you saw on the last one, that one also had a score key for some of it. What I would say to do if you don't want to score these is to literally just kind of look at each behavior and kind of just go through the DSM and just determine like what is meeting the criteria. This one right here is always often on the go or acts as if they were driven by a motor, right? Well, if they have very much true or pretty much true scored, then you're going to say, okay, well, that's a criteria right there for the ADHD because that's coming right, from it in a way. So let's find another one on here. Excitable or impulsive, because you can have too much excitability, right? So again, I'm not a big fan of some of these screeners. You'll find certain screeners, they're outdated, what have you, right? Unfortunately, screeners don't often get updated, and it's annoying. Who's ever thought that? Who's ever looked at screener questions and you're just like, what kind of question is that, right? It gets really annoying, but it is what it is, especially when these are like self-induced screeners. So sometimes I like to go over the results with them if I send it to them. I like to go over it with them just to make sure they understand it, what we're asking for, what we're looking for. And again, this is subjective, which goes back into your clinical interview anyway. Seeing if there's any questions here. Perfect. So that was for children. That was all for children right there. We're gonna go into the adult. I like the adult ones a little bit more. So for those who want to know, we at my practice Superior Center, we specialize in ADHD. Over 90% of our people are seeking us either because they have ADHD or they think they have ADHD, and that is our main bread and butter, right? My personal specialty is working with the adult. I love working with some good adult ADHD, especially between the ages of 18 and 40. I love helping these younger adults kind of just navigate the transitions of life and also help them learn more about their diagnosis. So the adult ADHD self-report or the ASRS, this is one of my favorite ones. But there's one major critique that I do have of it, and you'll see why in a minute here. So there's two parts to this one. There's part A and part B. In the in therapy notes, if you are a private practice owner and use that as your electronic medical record, this is in there and it scores it for you and it's great. However, it's very easy to score this one anyway. So do you see the shaded boxes here that are gray? That's going to be what's considered positive. So if your check mark falls in here, you're scoring a point. Now, here's where this gets really weird and really just, I don't really get it. But when you score these, there's two parts, as you can see. There's part A and then there's part B. Part A is the one that gets you the positive screener for ADHD. Part B, you're just gathering information. Don't ask me why. I wasn't there when they made the screener. But I love this screener because it goes over the symptoms for ADHD pretty decently for an adult. So for me, I'm just like, the score, I need to make it match up to the DSM anyway, but I get it. It makes sense. So you're just going to see what falls into the category for the most part of often or very often, with the exception of a few of them. You have some that will fall into the category of sometimes. So that would include often, how often do you have trouble wrapping up the details of a project once the challenging parts are done? How often do you have difficulty getting things in order when you have to do a task that requires organization? How often do you have difficulty or problems remembering appointments or obligations? And then down here, that would be how often do you have difficulty keeping your, oh, I'm sorry, I'm on the wrong one. How often do you have difficulty concentrating on what people say to you, even when they speak to you directly? Do you leave situations or seats in meetings in which you are expected to remain seated? When you're in a conversation, how often do you find yourself finishing the sentences of the people who are talking before you can finish it themselves? And how often do you interrupt others when they are busy? For whatever reasons, those are a positive for sometimes too. However, remember the DSM, they said often. So keep that in mind. Even though it says on here they're going to be a positive screener, The DSM literally says word for word, often has this, often has that. So I would typically just go off of what says often and see what makes sense to the DSM, because even if this says, positive ADHD screener, it still doesn't match up with the DSM. Does that make sense to everybody? Okay, perfect. But this one is a pretty simple one. All right. This next one is going to be the Copeland assessment. Oh, I didn't mention this in the previous one, but the ASRS is also for the first 6 months, or the last 6 months of the last period. So your last 6 months, essentially. I don't know why I said that weird. The Copeland symptom list is a summary. This is 18 to now, okay? So how this one works, this one is very simple. This is a long one, but this is the most simple assessment ever, just so you know. And it'll get you a lot of good information. So for this one, all you're doing is in these categories right here. You're just seeing how it falls in. Not at all, just a little, pretty much, very much. And whatever that client says or marks, you're just getting a percentage and then a score. So you have all these different ones right here. Here, I'm going to go ahead and blow that up a little bit. Now, as you read these, some of these are a little outdated too. I would argue that this one's an outdated one. Nicknames such as Spacey or Dreamer. We don't go off of nicknames or name calling for a diagnosis, but hey. This one I would reword a little bit actually when I do assessments. I usually say something like, do people say you space out a lot? Have people mentioned that you daydream a lot or they catch you daydreaming, anything like that? Because we don't go off of just like, hey, Spacey, because that's rude. Some people are just rude. I don't think people are saying that anymore either. It's a little outdated. You get what I mean? But we have a lot of these that's going to give you good information on you, so you'll be able to get percentages and scores based off of their inattention and distractibility, their impulsivity, their overactivity, their hyperactivity, their underactivity, non-compliance. Here's my two favorite questions on here, by the way. So there's forgets unintentionally, which is they put quotes on forgets unintentionally, which means you just forgot. And then there's forgets as an excuse or intentionally, meaning you're a liar. They didn't want to just say you lie and say you forget things. So that one's always fun to ask people because I have to clarify clinically, and do you lie about this? And half the time people will even ask me, they'll be like, are you saying I'm a liar? And I'm just have to be like, yeah, do you lie about forgetting things? It's really funny. But then you can also measure their underachievement, disorganization, any learning problems they have, emotional difficulties, peer relation skills, and then their impaired family relations right here. One thing for this one, I will say for the language, easily frustrated with spouse, children, I will add partner into this too. And I usually when I read this to them, if I'm doing it verbally, I'll say easily frustrated with spouse, children, or partner, overreacts, or may punish children too severely if you have children. Just because sometimes, if they read this, they'll be like, oh, that doesn't even apply to me, whatever. It's a really wordy question. But if you somewhat apply to this, if any part of this applies to you, then we can answer it. All right. But other than that, it's just getting a percentage. And then right down here, this is how you score it. So this is going to tell you how you score this. So scores between 35 and 49% suggest mild to moderate difficulties. Scores between 50 and 69 suggest moderate to severe difficulties. Scores above 70% suggest major interference. So if you are screening at least a 35% on each section, you are screening a positive for that one, right? So check this out. This one, and this one are all dealing with hyperactivity, maybe a lack of activity, impulsivity, a lack of attention, all that kind of stuff, right? So these parts right here are going to be your main parts when diagnosing ADHD. Now, all this is going to give you supplementary information. This is a screener tool that's going to make you look really legit too. because you're going to write a letter to their doctor or you're going to put in their diagnostic plan that you fax over to the doctor for justification of ADHD. Client is scoring at 70% for inattention and distractibility, which indicates, hold on, which indicates major interference according to the Copeland assessment or the Copeland symptom list. This is going to make you sound really legit because it is making you really legit. You're assessing for a lot of different things. All right, let's go ahead and go to the Wender, Utah. Now, I'm going to show you both versions, and I'm going to show you the version I like to use. So I guess that's both versions, so but whatever. But the 25 question one is the one I like to use a little bit more. What? Why is it not clicking? Dang it, it's not clicking. Okay, that's fine. We'll do the 25 question one because that's the one we need for ADHD anyway. So there's a 61 question version of this, and then there's the 25 question version of this. I do the 25 question one because I'm looking for symptoms of ADHD. However, sometimes I will use the 61 question one. I cannot pull that one up right now because it's in the library of my therapy notes. And if I log in on here, you guys are gonna see like my therapy notes charts, and that's a HIPAA violation. So we're just gonna go ahead and go off the 25 question one for tonight. So essentially, how this is going to work is you're going to have a score of up to 100. You're going to see how this matches up with the DSM. The score for these, we're going to blow this up a little bit. It's going to go not at all or very slightly, followed by mildly, followed by moderately, followed by quite a bit, followed by very much. Now, if you do this, depending on, you'll see numbers on here for some of these PDFs if you look at different ones. This one doesn't have it. But you'll see numbers that'll go for right here. It'll go 0, 1, 2, 3, or 4, with 4 being very much and 0 being not at all or very slightly, right? Sometimes what I like to do is I like to just have people tell me between 0 and 4, how likely is this like you? Because sometimes that helps them not overthink, like, ooh, is that a quite a bit? Is that a very much? Is that a whatever? So then they'll tell me, okay, I think that's a 3. And I'm going to tell them, okay, so for concentration problems and you being easily distracted, that's going to be a 3, which means quite a bit. Does that sound right? Does that make sense to you? Yes, that makes sense. Okay, we're going to move right along. Now, this is for when you were a child. This is not for current day. I want to make that very clear. This is your childhood history. It is very important that we assess for ADHD in our childhood because in childhood is when we need to have the ADHD symptoms. You don't just develop ADHD when you're 25. You don't just suddenly start forgetting a ton of stuff when you're 25 and daydreaming and losing things for no reason, right? When you're 25, like when you're 25, 30, 40, if that starts happening right then and there, you have a medical problem. You have cognitive decline. You might have a brain tumor. I had somebody who did an ADHD assessment with me, and this was like a few years ago. And basically, what ended up happening was they scored positive on everything for the adult and nothing on the childhood. They didn't recall anything in their childhood. They couldn't remember it. That we even had like their parents come in, and their parents were pretty objective. One of their parents was a doctor. Not that that matters too much because sometimes the doctors have their own biases, but we get it, right? And we just were not narrowing down any ADHD symptoms. There was something else clearly going on. So I had to kind of refer them for a medical appointment. Turns out they got a scan done and they found out, a couple weeks later they had a brain tumor that was causing all of these new symptoms for the last, 6 months of time, right? So it's very important that we have a childhood history of this. Now, the barrier to this is that some people don't remember their childhood very well. If they can't remember it at all or extremely little, then we need to refer out for medical testing or we need to give them another mental health diagnosis, right? Because that's just going to be something where it's like, okay, we need something else here. Something's going on here. It is not mental health because it wasn't before the age of 12 that these symptoms were in place. So when I do this assessment, I tell them, tell me about your childhood between the ages of kindergarten or 5 to like middle school years, 12, 13, 14, somewhere in there. Try to figure out some memories. Most people can remember a decent amount to where we can continue with this assessment. So as far as having ADHD goes, we have a score of 46. If they score 46 or higher, then they are being positive for ADHD. Now, as a disclaimer, again, we want to point this out. I have to say it repeatedly, and hopefully it's ingrained in your head. Just because somebody has a positive or score or a negative score doesn't mean anything. So what I like to do after I get the scoring is I like to see, what's kind of going on in here. How many things are happening and how many of these things can I link up to the DSM criteria? So concentration problems, easily distracted. I have at least one or two symptoms of mine already that I can put that through. Nervous or fidgety, we could put that to something a little bit easier. Anxious or worrying, anxiety comes along with ADHD, but I wouldn't write that in blood to say, okay, just because you're anxious and worrying, because it's not technically part of the DSM criteria anyway. But this assessment does just add further evidence that you probably have ADHD or not. And that is going to be the screener tools we're going to go over tonight. If you do your own independent research, there will be a lot more screener tools for ADHD. And there's a lot of screener tools that we use to rule out ADHD or to rule in another mental health diagnosis or to rule out another mental health diagnosis. So some of them, we have the GAD-7, PHQ-9. Most of you are familiar with those. PCL5 is for PTSD. That's a very good one for PTSD diagnosing. It's pretty accurate, actually, to the DSM criteria. Our ACE assessment, a social anxiety assessment could be the CIAS. And therapy note, these are all, by the way, right here. All of these ones that I have listed are in therapy notes. So if you're a private practice therapist, these are in therapy notes and they will be scored for you. So whether you do them verbally or whether you have them do it themselves, it'll score them for you, makes your life very easy and very easy to interpret. So you're not spending hours on end or, a lot of time on end trying to score these things. And again, you do not have to use all of these types of assessments. You can even add whatever you want, but remember, it comes down to the clinical interview and the biopsychosocial and their actual client history. So do not use these tools and see they all came out positive or negative and diagnose based off of those scores alone. I think we're kind of past that at this point. I've said it a million times, but these are a guide. It's a different training. Any resources for ADHD linked to obsession or difficulty limiting pornography? I don't have a training specifically that I'm aware of. I can find that potentially. Let me do some digging on that one. But it definitely is linked. I do know that. Porn is one of the biggest ways to produce dopamine, and with ADHD, you will see a lot of people with ADHD. They don't use the term sex addicts anymore, so I don't know what the actual correct term of that is. If there's anybody who is a sex therapist and knows that term, let me know. I don't think they ever used the term sex addict actually, but that was a social term that people would use. But people who used to label themselves sex addicts or porn addicts, I think now it's more of like a compulsive behavior. They like to label it now. So anyone who wants to correct me on that, just throw that in the chat for me, please. But people who used to be labeled those things often have ADHD because sex and porn is a very big way to get dopamine without actually using drugs. And if you think about it too, it's also, if you're looking at it from the addiction or the compulsive behavior lens, that is also harm reduction in a way because you're not putting a substance into your body. All right. Okay, so we've kind of preached about this on and off tonight and how you do this with the screener versus the history, but how do we determine a diagnosis of ADHD? So you've heard me preach all night. You've heard me yell at you all night. I want you to watch this guy for a little bit here, and he is going to give you another way of how you can diagnose ADHD from his perspective. Just so we have two opinions, you will see that we are pretty aligned though.
Unless you just generally like looking up medical conditions on the internet for fun, you're here. because you think you or another adult you love might have ADHD. And if you do just generally like looking up medical conditions on the internet for fun, then please put down your phone and step away from the WebMD as soon as possible. Take a nap, take a walk, give yourself a break. Otherwise, welcome. Pull up a chair and a cup of coffee or tea or a fidget cube. I use a handy fidget pen. I'm Dr. Jared DeFife, psychologist in Atlanta, Georgia, and today we're going to talk about how do I get tested for ADHD. But first, remember to subscribe below and click the bell to get notified when new videos release. Here we go.
I love his 90s sitcom music, by the way. Shoot.
But first, remember to subscribe below and click the bell to get notified when new videos release. Here we go. If you're an adult and you think you have ADHD, just reaching out for help is probably not the easiest thing to do. ADHD can make it really difficult to get started on things, get organized, execute a plan, and get important things on the schedule in the first place. To get diagnosed with ADHD, you have to do things like find a clinician, call a clinician, schedule an appointment, show up to that appointment on time. Ugh, it's like a whole detailed list. And keeping to everything on the list probably isn't one of your strong suits. But here's the thing about all of that stuff. Despite all the aggravation and coordination that it takes to get evaluated, getting good quality help is so worth it. If you have undiagnosed ADHD, you've probably already been struggling with things like getting started on things, managing your finances without late fees. Oops. Following through on all those big ideas and big projects that you'll figure out someday, not today. Showing up to things on time, turning things in on time, paying your bills on time, getting to sleep on time, getting out of bed on time, eating meals on time, pretty much anything to do with time, taking care of yourself and your health, making and keeping good relationships. That's right. Unmanaged ADHD affects so many areas of our adult lives. It's almost like stumbling around, bouncing into walls without your glasses on, or getting nowhere because you can't remember where you left your car keys. Pro tip. Forgetting your glasses all the time and losing your car keys frequently may be signs you have ADHD. Now, before you say, well, everybody loses their car keys sometimes, so everybody must have ADHD. Well, everybody's heard a Taylor Swift song at some point. It doesn't mean there's no such thing as a hardcore Swiftie. They're out there, they exist, and it's the frequency with which things happen that matters. ADHD is real. It's the subject of thousands of research studies, and it affects millions of adults in the US. Okay, but besides internet quizzes and satirical unofficial test videos on YouTube, see the link below for a few chuckles. How do I know if I actually have ADHD? Quote famed ADHD researcher Russell Barkley from his book, Taking Charge of Adult ADHD. He says, to get started, get evaluated. But before you do, here are two key pieces of information to know about adult ADHD evaluations. Number one, there's no magic test for ADHD. This isn't wizard school, Harry. Wait, am I allowed to use the name of a specific wizard school or am I going to get sued? Okay, this isn't a generic wizard school name, Harrison, and there's no magic sorting headgear to put on your head. I hereby proclaim you Rufflepuff, inattentive type. There's no special puzzle task, brain scan, blood test, or computer game that will magically tell you if you have ADHD. It just doesn't work that way. Instead, psychologists and other clinicians, psychiatrists, social workers, counselors, use a variety of tools as part of a detailed assessment process. The most important tools that any clinician will use as part of the assessment process are right up here, their ears and their brain, because good quality clinical interviewing is still the most effective gold standard tool for ADHD assessment.
He just endorsed me. I'm just going to point that one out. Remember, there is not a single tool that is going to magically diagnose ADHD. Like he said, you are going to have to do a really good, thorough clinical interview. So like I said, even if you don't use any of these screener tools that we went over a little bit ago, you're going to want to be able to at least do really good, thorough clinical interviews. and compare it to the DSM diagnosis.
So that means that your clinician is going to ask you questions, a lot of questions, like all the questions, and they should listen to what you have to say. Also, your clinician should collect a lot of standardized numerical questionnaire data to compare your results against scores of tons of other adults who have or haven't been diagnosed with ADHD. Don't worry, there's no math involved, and definitely no Scantron forms, just a whole bunch of paper and pencil questionnaires. All this means is that this process takes time. An ADHD diagnosis doesn't happen in a quick 20-minute visit. Your clinician should spend time getting to know you and your experiences, and if possible, someone else who cares about you and knows you pretty well. Wait,
I just want to point this out since he said this too. So he is correct too. The best way to also get diagnosed is for ongoing assessment and evaluation. Now, some people need these evaluations to be a little more formal just because they're trying to get stuff for school in place or what have you, right? But the best way to have the most accurate diagnosis is if you're working with someone through therapy long term so that you too can see these symptoms manifest over time. That way you get the most accurate amount of data.
what? Yeah. See, one of the things about people in general that's especially true of adults with ADHD is that we aren't always the best observers of our own behaviors. That means, with your permission, of course, it's always a really useful idea to include third-party information from family, friends, or people who know you well if they're trusted and available. Along those
That is not always available, by the way, just so you guys know, but that if you are able to get that information, please add that into your assessments as well.
lines, you should try to have any of your records available, from medical exams, previous therapists, angry letters from your third grade teacher about that time you failed to complete your science project on time, and instead hastily threw together a baking soda volcano in the cafeteria mashed potatoes during lunchtime. Basically, any information that helps your clinician get to know you and your history better. Also, you should have a general medical exam to rule out problems that can look like ADHD. Things like blood sugar problems, hearing problems, sleep disorders, and more. So check with your physician. You have been keeping up with your regular medical checkups, right?
I know I keep stopping, but I just want to point this out too. This is a big reason why I am a little bit critical of self-diagnosis. I know that's been a big thing that's happened culturally with people, within the ADHD community and culture, right? You'll see a lot of people online advocating for self-diagnosis now. I've seen some that say that it should be just considered just as valid as a formal diagnosis. I do not fully support that, and I do think that there's a difference between people who do a ton of research on themselves versus somebody who just finds symptoms on the internet and then goes with it, right? The fact is that you're going to need to get a thorough medical exam, or at least have had some sort of exam done in order to make sure that that is not affecting that either. Now, as far as childhood history, if you can get the childhood history down or have some proof of the childhood history, then we can feel that that's a pretty safe bet too, because if you're still having the symptoms from childhood to adulthood, then you probably are still going to qualify for the ADHD diagnosis anyway. All right, I'm going to go start him again now.
And flossing your teeth, right? Good. Finally, some clinicians might use some educational performance tasks to learn more about your general level of cognitive functioning or memory and get detailed information about things like learning differences or disabilities. Others may use types of scanning equipment or computerized tasks of attention and performance. But it's important to note that there's some disagreement about the effectiveness of using these kind of measurements for the purposes of diagnosing ADHD. There is no clear link between ADHD and IQ, and many task-based assessments either weren't specifically designed to assess ADHD, or they miss a substantial percentage of adults who actually have ADHD but still do well on the tests. Why is that? Well, those kind of assessment tasks are short, they're novel and interesting, like video games, and they don't tend to accurately reflect the kinds of complex skills and situations we actually have to navigate in the real world. Things like managing our social relationships, cleaning out and organizing your closet, or dodging through rush hour traffic to get to a new place you've never been before and actually finding a way to show up on time. Now that you've learned a little bit more about what to expect from an ADHD evaluation, it's time for point number 2. Find a knowledgeable professional. While there are different types of licensed clinicians who can properly diagnose a range of mental health conditions, evaluations for adult ADHD are usually conducted by clinical psychologists, psychiatrists, neuropsychologists, or behavioral neurologists. This next part is unfortunate, but most importantly, don't just assume that any clinician you see inherently knows much of anything about adult ADHD. Heck, I didn't know that I had it, and I graduated with a PhD in clinical psychology. I even finished a clinical fellowship at the same Harvard training hospital as this guy. That's Dr. Edward Hallowell, a psychiatrist who literally co-wrote a best-selling book on adult ADHD because he didn't know he had it either until late in his own clinical training. For years, no, for decades, I struggled with things like depression and anxiety and organization and social relationships. And never once did any of the clinicians or physicians I saw mention anything about the possibility of ADHD. But I did struggle in so many different ways. There's some days I just wish I could go back in time and shout to so many people, why did you miss this? Why didn't someone just tell me? But I can't. I can only work with what I've got now. And that's a big part of why I'm doing something like this video right now, because I don't want other people like you to struggle and feel lost for the longest time like I did. So if you suspect you have ADHD, get started by getting evaluated. And get evaluated by a knowledgeable professional who will listen to your concerns, collect standardized information, and will talk to important people in your life and take your concerns seriously. If the clinician does all of these things and then tells you, I don't think you have ADHD, and here's the data as to why not, be open to hearing that too. But whatever you do, don't give up. Get help, get support. It will be worth it. Check the description below for some links to additional information. And
One thing he did not say that I also advocate for is also for clients anyway. Do not be afraid to get second opinions either. Don't diagnose a shot, but don't be afraid to go get a second opinion, because some people will dismiss you. Hopefully, you're not going to be one of the therapists who dismiss them, though, because you're taking this training. Come on. Okay, there we go. All right. So as far as how to conduct an evaluation, to help summarize some of this, you want to get their biopsychosocial history. You want to ask for clarification on certain areas and get context. Have them complete screeners or do them with the client. Get context from those screeners. Receive any previous diagnostic or health paperwork for review, and then schedule a follow-up with them if needed. And if you can get collaborative information from parents or past teachers or current teachers, or anything like that, that would be super helpful as well. So as far as how to interpret an evaluation, you want to first organize your assessment. You want to, fix any of the typos, go through all the info, because I'm sure you're not writing complete sentences as you're doing it. If you are awesome, because that would not be me, because I'm usually like bullet pointing everything and then cleaning everything up, right? You want to review your biopsychosocial and the screener scores, as well as how they align. Review any history forms you have. This would be your clinic history form. This could be a history form that maybe got from their teacher. History form could also be a letter that they write for you. Anything you can get, though, just review all of it, lay it out, figure out all the data, dissect it. Write down any follow-up questions that you may have for the client for clarification. So one of the things that I do in mine is I give myself at least a week between doing the assessment and getting all the information and organizing it, so that way I have time to ask specific questions, and we schedule we schedule it for 30 minutes. It's usually about 5 minutes long, though. But we will schedule a consult together just for me to get clarifying information now that I've had time to actually think of additional questions. And then make sure your symptoms are meeting DSM-5 TR criteria and are not explained by other health conditions, substance use, other mental health diagnosis, etc. As far as ruling out diagnoses, if the symptoms are better explained by physical health condition, substance use, medication side effects, or another mental health condition, then it can be ruled out. Now, if it's kind of overlapping, that's where you get into that weird zone of like, okay, which came first, the chicken or the egg, right? For substance use specifically, I would say if the person is still using and they've never been diagnosed with ADHD previously, your safe bet right now is to just diagnose them with a substance use disorder and wait for a period of sobriety. That is the most accurate way to do that anyway. I know some people there are some people that will tell you to diagnose it when they are first coming to rehab because co-occurring disorders and substance use go along hand in hand. That's very much true. But if you do that, you could be playing with fire by mixing psych meds with somebody who's just coming off substances. So I would just say for the purposes of being safe, it's just better to get a period of sobriety when they're getting sober and they're newly sober. All right. Well, let's go ahead and do a case study real quick here. So, hold on 1 second, y'all. The throat is acting up. Okay. So, Kelly is age 30 and female. She's coming to you for an evaluation after noticing that she has been experiencing excessive distractibility and difficulty gathering her thoughts. Kelly states that she is confused many times during the day and feels like her symptoms started 2 years ago. She is scoring a 5 out of 6 on the ASRS and is scoring a 70% on the Copeland symptom list. This is indicating a positive screening for ADHD symptoms, specifically for inattention noted. She has scored an 11 for the Wender, Utah assessment, indicating a lower score for ADHD childhood history. In your biopsychosocial, you noted that Kelly has been sexually assaulted 3 years ago and reports heavier drinking both in her clinical interview from the biopsychosocial and on her cage screener. Kelly reports having at least 2 glasses of wine per night and sometimes more. Kelly also reports having flashbacks, nightmares regarding the assault. According to her PCL5, she has a score of 35, indicating a positive screening for PTSD related symptoms. What diagnoses would Kelly best be qualified for with this information? So you have some adult ADHD screeners being here, but you also have a history of substance use going on right now. You have a continued use of current substance use with alcohol use, I should say, right? And then we also have PTSD here. So based on off of all this information, we're probably going to go with a PTSD diagnosis and or a alcohol use disorder diagnosis. And the reason behind that too is that her childhood history is a little bit lower, and we are dealing with symptoms of PTSD and alcohol use disorder right now. So if the childhood history is low, especially, and there's no previous diagnosis, you can go with the alcohol use disorder because of the drinking alone. The PTSD is because of the assault and the symptoms she's experiencing. So again, for PTSD, we have flashbacks and nightmares. We have distractibility, could be better explained by that at the moment. The PCL5 screener results are also some supporting data, the time frame of the symptoms, and then alcohol use was noted, which is common to medicate PTSD. It's also common to medicate ADHD though too, so that is a little bit of that's just something if you work with people with ADHD, you find that out. A lot of people with ADHD, their drug of choice is alcohol. The next one is going to be THC. All right, now let's go ahead and do this one. So this one's going to look pretty similar. So Kelly's coming to you for the evaluation after she noticed she has been experiencing excessive distractibility and difficulty gathering thoughts. Kelly states that she is confused many times during the day and feels like her symptoms started in childhood around age 10. Okay, so we have a little bit of a change of story here right now, right? She's scoring a 5 out of 6 in the ASRS and is scoring a 70% on the Copeland symptom list, indicating positive screening for ADHD symptoms, specifically for inattention noted. She has a score. She scored a 43 for the Wonder, Utah assessment, indicating a higher score for ADHD childhood history. So I believe we said earlier it was 46. I always have to reference that one back, but it's still kind of on that cusp, right? So it's kind of like, okay, we give some grace and we move along. And again, we're only using it for supplementary info and a little bit of supporting data. In your biopsychosocial, you noted that Kelly has been sexually assaulted 3 years ago. So we're dealing with ADHD symptoms as well as trauma right now. She was sexually assaulted 3 years ago and reports heavier drinking both in her clinical interview from the biopsychosocial and on her cage screener. Kelly reports having at least 2 glasses of wine per night, sometimes more. Client also reports having flashbacks and nightmares regarding the assault. According to her PCL5, she has a score of 35, indicating positive screening for PTSD symptoms. What diagnosis would Kelly be the best qualified for primary diagnosis with just this information? Well, for primary diagnosis, kind of a little bit more subjective in this case, you could probably go with PTSD or alcohol use disorder still. I would probably, if I were to do this, I would probably say that PTSD is the primary. And the reason I would say we would put it as primary for the evaluation purposes is because it seems like she could be drinking because of the PTSD. So I would probably order it PTSD, followed by alcohol use disorder, followed by other specified ADHD. The reason I'm including even the other specified ADHD at this time is because there is a childhood history linked there too. So we need to make sure once there's a period of sobriety and the alcohol use disorder is in more remission, but there is a good enough history to where I feel comfortable putting the ADHD label on there. Does that make sense to everybody? Okay, so we do have a question. Can you repeat in ADHD? You'll see alcoholism, and then what was the other? THC, I noted. THC, you'll often see that from when I last researched and looked that up. But alcohol is pretty big in the ADHD world. THC is just kind of like a given anywhere now, just because there's a lot of more places that are legalizing and accepting of it. So, which is great because we love to see that. I'd love to see eventually decriminalization for substance use in this country, but that's neither here nor there tonight. Am I right? All right, so we're gonna move along from that. Okay, so why all three? Why are we including all three tonight? Okay, so because of the flashbacks and nightmares for one, needing a period of sobriety, we're gonna need that period of sobriety to be there, which is why we have the other ADHD and not just full ADHD combined hyper inattentive or hyperactive. The PCL5 screener results, that's your PTSD screener. The time frame of the symptoms makes sense. And then needing a period. I feel like that is a typo. That might be something I know since this is the beta class. So what are we talking about needing a period? We're gonna go back in and look, see if that meant anything. Oh, needing a period of sobriety. There we go. That was meant to be deleted out. Never mind. I was like literally having a brain fart right there. So ignore number 5. I will actually make a note of that later to take that out because that should not have been there. I was literally trying to figure out like what does needing a period mean? I'm confused. Okay. All right, so after the evaluation. So for coordination, accommodations, and advocacy, this is the work that we're doing after the evaluation. We say, so long, friend, get on out of here, go take on the world, right? So what comes next is first they're going to be like, okay, have a nice day, or we tell them to have a nice day, right? Get on out of here. So then we ask for the results to be, they'll probably ask for the results to be sent to their doctor or therapist. Now, for number 1, for a lot of my people, this is it. This is all we sometimes have to do. Have a nice day. Thank you for doing this. I'll email you your results. Well, whatever the results to you, right? We'll upload them to your portal. A lot of people are just literally looking for ADHD evaluations for their own knowledge. When they want to coordinate it, they're going to ask you to send them to their doctor or their therapist. They're probably going to need you to give them a referral for additional testing if needed. And they'll probably need some assistance with accommodations. Not every time. Most of the time, it's just number 1. Great, have a nice day, thanks. Gonna go tell my current therapist about it. Or maybe you're gonna be their therapist. Maybe it's see you next week. So in the case of they want the evaluation from themselves, sometimes clients just want the evaluation for more information on themselves and their lives. They're just trying to, figure out like, do I have this label even? Do I not type of deal, right? So you'll often see this a lot of the time with ADHD, especially because it's becoming so normalized in adults now. In this case, you're going to want to print a copy of their evaluation and give that to them, certify, mail them a copy, or secure email them a copy. So this is depending if they're telehealth or they are in person or what have you, right? If they're in person, you have a printer, just print it for them. Just give them that copy. Always upload it to their chart though, in case you need to like, do it later, but that's kind of a given in our field. And then recommend to have clients sign a release for themselves. That's just so they can't say like they gave the release to somebody and they or you gave the assessment to somebody, or I guess I should say they do because you're handing them the packet. But that's just so you can note that I gave them a copy to themselves and they can't say later, I didn't want my doctor getting this, and now I have this medication reaction that happened, and I didn't give them permission. They violated HIPAA and yada yada yada, right? So get them to sign a release for themselves to get their record. They want the results for their therapist. So if you're not their therapist, somebody may be seeking an evaluation to send to their therapist in order to better help them with their therapy. So when this happens, send a copy of their evaluation to the client and their therapist by fax, certified mail, and or secure email. The client must sign a release of information to send to their therapist. That is a no-brainer at this point, probably in our field, but I'm just going to say it for the record, get a release, get a signed release. They want the results for their doctor. Okay, so for medication coordination, their doctor, health reasons, whatever, right? Client may need it for an evaluation for ADHD where their doctor will prescribe medication. So in this case, we're going to send a copy of the evaluation to the client and their doctor by fax, certified mail, or secure email. So make sure it's secure if you haven't caught on already. Client must sign a release of information to send to their doctor, and a letter might need to accompany too. So what I do for mine in therapy notes is there's this thing called an intake note. It's what I use to show that they've done an assessment too. And it'll say diagnosis, justification, and plan. I usually just write there the plan and my recommendations. If you're someone who's more of a letter writer or you want to write an advocacy letter, then you may want to just write the letter and sign it and send it with your stuff that you send them. Sometimes the letter is easier too for the doctor to read because if you put the letter on top, they don't have to go through the full packet. And you can just make it really clear on one sheet for them. Fun fact, I also do therapist business and marketing coaching, and that is a very easy way for you to get your branding out, is sending a letter with your letterhead if you have a private practice, and your logo on it. And also when you send it to these doctors, it makes their lives easier and they're more likely to refer to you. Just as a little fun wink wink if you if you do private practice. It's a little extra step, but it really helps. All right, so here's just an example that you can just briefly look at real quick. So right here, you have the patient name, you have their date of birth, and you also are going to have their diagnosis right here. So in this case, Ashley has F90.2, attention deficit hyperactivity disorder combined type. The reason I put the code is because sometimes they copy and paste into their chart from our letters, which gives the doctor an easier time. Other times they have a scribe and they pay someone to do their notes, yada yada, whatever, right? So, but if you put the code, it'll make them have an easier time. It's good coordination of care and it's good marketing for your practice, just so you know. All right. Next part is going to be the recommendations right here. So in this case, it's recommended the client begin individual therapy every 1 to 2 weeks to address issues related to focus regulation, hyperactivity, working memory, and overall executive functioning. In addition, it is also recommended that the client seek a medication evaluation from their primary care physician or psychiatrist to determine if medication would be the best course of treatment given their most up-to-date health status. So this is just the recommendation, making it very clear what it is. Please reach out to me at this number if you have any questions. I would be more than happy to help coordinate care for our client. Coordinate care for our client. Emphasis on that R. Again, good coordination and good marketing. Good healthcare coordination is always good marketing, y'all. And then don't forget the signature with the credentials. If you're the owner of your own practice, just as a marketing tip, always sign its therapist and owner or CEO. It makes it sound like the owner's more personal with you, even though we're all solo business owners. Okay. So referrals for testing is needed. So sometimes we're going to have to refer out for psychological testing, and this can be especially hard for clients to hear because they came hopeful that they can figure out what's going on with them today, right? So in addition to this, psychological testing may not be covered by some insurance plans, in fact, a lot of insurance plans, and it can be very expensive. We're talking thousands of dollars here, right? So this is not something fun anybody wants to hear coming to an evaluation saying I think you need to go get tested, right? So I recommend you use this sparingly unless it's very complicated with what they're going through, right? On top of this, many outpatient centers have months to years long, well, not years, but a year, sometimes a year. Though I've heard of one with a 2-year wait list, which I think is ridiculous, but that's neither here nor there. If you have a 2-year wait list, you should be hiring someone. I'm sorry, you should be hiring someone if you have a 2-year wait list. They have a year-long wait list to get tested. So what do you need to do when you're actually referring for testing? So first and foremost, you're going to always want to stay on top of who is providing the best psychological testing with as little weight as possible. The one I told you all about, and I'm not going to drop names, but the one that I told you about that has like a 1 to 2 month wait, I've also heard mixed reviews on. And more recently, I've heard negative reviews on, which means it's my duty to try to find a better resource. Especially because I've heard a repeated pattern, right? So I want to find a better resource to not just get people in quick, but get them in with quality. Reassure the client and validate their emotions because this is not an easy conversation to have, let alone hear. If your organization offers this in-house, speak with your supervisors or director to see how long the wait is for testing. Perhaps, depending on how severe the symptoms are, you could also get them moved up. And when the client finds a location for testing, offer to coordinate resources and facts over your evaluation. All right. As far as advocating for accommodations, clients may seek accommodations for their workplace or education, which can be anxiety producing and produce a lot of unknowns for the client, as well as feeling embarrassed or shame, right? So your help can make the process of this a whole lot easier just by being friendly, being kind, and being willing to help. So as far as the first steps for accommodations, whether this is for work or school or what have you, depending on what setting we're talking about. In this case, we're going to be talking about work and school, but there's a few other places you can probably get accommodations for. Direct the client to their human resource department or office of disabilities. And the reason you're going to want to do this is because every single place has different ways they want this, right? Some people want the client to fill out a form first. Some want you to fill out the form first. Some want you to write a letter. Some people want you to do a psychological evaluation and get all this stuff in, right? Side note, I don't know how much of this is legal that they request, by the way, because I wonder how much stuff they really truly need, but I am not the lawyer. I am just telling you what happens, right? So I can't tell you if all that is reasonable or not, but that's neither here nor there. So everybody's going to ask for something a little bit different. So refer them to the Office of Disabilities or refer them to their Human Resource Department. Discuss accommodations that they could benefit from and specific challenges they are having. So you want them to kind of sort of map out their own accommodations. So I always say you could ask the miracle question and be like, in a perfect world, if you could just have any sort of accommodations you want, what would those be exactly? And we kind of formulate the accommodations from there. Okay, so you would want to just be able to come into work whenever you want. Why? Now, I'm probably not going to accommodate somebody or write a letter for someone to come in whenever they want, but I would clean it up a little bit. I would say, get them some flex time. I'll have them be able to come in up to 20 minutes early and leave 20 minutes late throughout the day to offer flexibility in their schedule if they're working on like getting to work on time. You want a whole new office. Why? So then maybe we would narrow that down to, okay, well, it sounds like you would benefit from a standing desk. What do you think of a standing desk? Do you want a standing desk? 9 times out of 10, they're going to say they want a standing desk, by the way, because most people with ADHD just hate to sit still all day in an office, let's say, right? So they would get a standing desk. So we would request that and we would justify why that would help their ADHD symptoms, why that would help their focus regulation. You want to help them if they even want to request accommodations. Some people don't feel safe requesting accommodations because some people might discriminate against them. Some employers might discriminate against them. This is the real thing that they face. So you want to help them determine, is this even the right thing to do? And do they feel safe doing this? And then finally, have the client sign a release to coordinate with the school or work if needed. All right, we're going to watch a video on ADHD accommodation versus modifications.
Once a child is identified as needing extra support, it doesn't matter if it's under the multi-tier system, under 504, or special education. There are two different forms of support. One's called accommodations, the other's called modifications. Accommodations are things that will help your child do the things that all other children are doing in the classroom. A lot of times caregivers will think that accommodations are crutches for your child, but on the contrary, these are stepping stools that help your child do the same thing that other children are doing. What are the most common accommodations that are used with children with ADHD in the classroom? Checking for understanding. This is where the teacher will come by your child's desk or where they're standing and ask the child to repeat or rephrase what she had asked them to do. For example, she said, please take out your pen or pencil. She'll come by and say, hey, what did I just ask you to do? Another accommodation is extra time. Children with ADHD cannot sit there and do all the assignments at one time. Sometimes they will need extra time. So teachers will allow the child to start the assignment in the classroom, but may pull them back maybe at recess or lunch or have them come into the classroom a little bit early to finish the assignment.
I don't agree with that one, by the way, but we can go on a tangent on another day. I don't believe in keeping kids from recess.
Taking frequent breaks. For a child with ADHD, it's important that they do have breaks, even at home for doing their homework. There should be allowed time to get up, go take a break. So 5 minutes doing an assignment, take a 1 minute, 2 minute break, come back and continue working. Students with ADHD will not sit for 20 minutes and do an assignment. Redirect is another accommodation that teachers will use. And this is just maybe calling out to your child and saying, we're working on number 3, and then helping them redirect to their activity. A copy of notes. Nowadays, a lot of students, especially in middle school and high school, the teachers will give lecture notes. Parents can request, or the child can request a copy of the notes, because students with ADHD have a difficult time copying notes off the board or keeping track of where the teacher is. Another accommodation is chunking, making sure that the assignments are broken up. So especially projects for students in middle school and high school, if they have the science fair project that's due in a month, chunking the steps for the child, in 2 days, you have to have this done. And by next week, you have to have this done. So chunking the assignment into different parts. Long-term projects, but also short-term projects. So if the child has a worksheet with 20 problems on it, then the child can say, okay, we're going to work on these 3 problems right now. Let's get those done, and then come back around and check on the child to see if they have done the 3 problems to move to the next problems. The last accommodation that I would like to share is called check-in, check-out. The idea is that the student with ADHD will check in with someone to verify what they need to have with them. So in the morning, when they get to school, they would check in and say, I have my agenda, I have my pencil, I have my backpack, and I have my homework. And then they can go over, okay, where do you go first? What are you doing second period? What are you doing third period? The idea is to have someone to check in, and then the same thing at the end of the day, check out. Okay, do you have your homework assignments? Do you have your papers ready to go home? Do you have your backpack? Are there any papers that your parents need to sign? And make sure they have everything. This check-in, check-out also works at home. So for caregivers, you can also check in with them before they leave in the morning. And then at night before they go to bed, check out with them, make sure everything's ready in the room. For students with ADHD, organization is a big key. I also want caregivers to think about accommodations as support systems for behaviors. So check-in, check-out can also be used for behavior reminders. So if a child is walking into a classroom, the teacher can say right before they walk in, hey, what are we expecting for you to do today? So walk to your seat, take out your pencil, and then they got a reminder about that accommodation. So caregivers, if you're having difficulty with your child staying in the seat or raising their hand, you can work on some accommodations where the teacher can assist them to remember what is expected of them as well. Modifications are also used in the classroom, but when you use a modification with children, they're usually under special education and it changes the curriculum. When a modification is placed, it means that the child is no longer learning what all the other children are learning. And that is okay because that's where your child is and that's what they need. But I do want caregivers to understand that there is a difference between accommodations and modifications. I'm just going to restate that accommodations are used across all three systems, the multi-tier system, the Section 504, and in special education. Modifications are only used under special education.
All right. All right, so some common accommodations for school you might see is anything related to seating, so providing preferential seating that's away from distractions and in other locations that's best for the student's learning. This could be near the teacher, away from high traffic areas, or in the front of the classroom typically. Allowing for extra time might be a good accommodation. Organization accommodations could be looking like providing extra help with organization, such as an assignment notebook being provided to them, and some sort of digital calendar. This is usually going to be on their phone or laptops or Chromebooks now, or folders for supplies. Creating a low distraction environment, providing clear, simple instructions, and break down long assignments into smaller chunks are going to be some teaching accommodations we could see. For note taking, providing typed notes or an outline of the lesson for students would be a great idea. In fact, I think most teachers, or at least most professors in college, pretty much do that now. They'll at least provide an outline or they'll provide the slides. So that way you have an easier time writing notes. I wish I took more advantage of those in college, actually, because my notes just looked really crazy. As far as test taking, using alternative test formats such as oral exams or assistive devices, using positive reinforcement and feedback and praising appropriate behavior. That's not necessarily a formal accommodation as much as I would probably just request that from a teacher, but sometimes that needs to be put into an accommodation plan. Using technology to assist with tasks such as a calculator or a tape recorder, if needed. And then as far as recording goes, allowing students to record their lectures and replay them at later times to take notes. And for presentations, students can record them at home listen to them and maybe even edit them a little bit. Oh, come on, work. There we go. Okay. So with that being said, do we have any questions that we did not get through? Go ahead and drop them in the chat for me. I don't see any written out. Someone said, "Fun fact: a friend is a vision therapist, and they see eye disorders and diagnoses often ADHD kids." Yeah, so that's actually a big reason as to why it's really good to get checked out for physical stuff. Because some people, of course, you can have like something like astigmatism, and have it with ADHD as well. But for some people, they can't pay attention or they're not focused because maybe they have a headache from trying to stare at the board all day. All right. I'm not seeing any questions come in. So I want to first of all thank you all so much for being a part of this. Oops, that was just some of my reference slides. Thank you so much for being a part of this tonight. You are going to get in the next few days the recording of this presentation. We're also creating a survey right now so that way you can give any feedback, anything we didn't cover, anything that wasn't clear, so that way we can make this into a CEU class. Again, you can follow me over at Instagram, TikTok, or at my website, and we can always link up there. Thank you so much. I appreciate you. I will leave this up on the screen.